Good morning, everyone. I'm going to give it another 2 minutes and we'll get started after that, but welcome and thanks for joining. We'll give it 1 more minute and then we'll get started. All right, let's go ahead and get started. Once again, thanks for joining. If anyone was not able to make our first session, the majority of it was recorded. You could review that, but in a nutshell, the first session, I did a lot of talking myself and went over a lot of MiHIN's vision and what we currently have in the works and what the purpose of the group is. And this week is where I start listening more and talking less. Before we get into the me listening part, we are going to go through the results of the topic survey that I went through, and then we'll dive right into the topic. I expect with some of these questions that it could I expect that we could make this last a lot longer than we're going to be here today. So I'll try not to waste any time. So let's take a look at the survey results. So these were the 8 topics that people prioritized. And I kind of grouped them here as the 3 at the top were the highest rated by far. You can tell it's those 3 are at least 9 points higher than everything else. So those are obviously our top 3 topics, and we're going to start with closed loop referrals and interoperability today. My proposal, which I'll ask everyone if that seems reasonable, is that these first 5 that are dark green and light green will be the topics that I for sure want to go through no matter what, and they'll be our first 5 topics. And I kind of wanted to leave it up to the group whether we wanted to keep meeting after 6 meetings, because the first one we already had. If we want to keep meeting after 6 sessions to go through the last 3 topics, or if those priority topics were what we wanted to get through. So I don't have a poll set up, but I'm hoping that somebody will, some of you will say whether you think it's appropriate for us to go through all of them or just the ones that were rated in the top 5. So that would cut out a topic specifically about cross-sector exchange, patient self-determination, and vendor relationships.
Mike, this is Diane Marriott. would you consider asking that question again, like a session or two before the close of the present series?
Yeah, that makes sense.
Does that, I don't know if that resonates with other folks.
Does that make sense to other people?
I think that's a good idea.
Okay, then we'll go through these 5 for sure. And as we get closer to the end, I'll resurface these 3 topics and see if we want to keep going or not. But I'm just going to plug in priority order the sessions as they were rated. So today we're going to start with closed loop referrals and interoperability. So the first question off the bat is the least on topic, but I didn't want to run out of time because we had a request to ask this question. So we are looking at gathering a group of community organizations to have similar feedback sessions with, and then ultimately the two might get together and have some joint sessions. But as we're convening those people, we want to make sure we have all the right people and make sure there aren't people who aren't on our list that we should have. So my first question is, are there organizations that your group is already working with that we should make sure have a voice in this conversation? Or are there organizations that you're not working with that need to have a voice that you're aware of? Yeah. And I suppose for this one, I do want to be a little comprehensive. So I'm actually going to ask people individually. And I'll ask for volunteer first. So that way I'm not picking on just the first person alphabetically, but after that, I'll go down the list. Is there somebody who has organizations they work with, they know of, that would go first?
This is Becca Fleming. I'm with Packard Health. I was not at the previous meeting, so I'm sorry if I'm a little off topic, but I'm assuming you mean community partners who essentially help address our SDoH needs of our population. Yeah. Okay. Yes, we have tons. You just want me to go down the list, or what is, just name a few?
Yeah. Yeah, whatever you can do in a short amount of time. You don't need to be a totally comprehensive list. But
yeah. Well, you know, our big one is our food gatherers who does all of our food pantry work. So they're a huge partner. And then we work with Phoenix Mobility to coordinate transportation for our clients. And I'm trying to think what else. Legal aid, if folks have legal issues they need help with.
Okay.
I would say those are our top 3.
Awesome. Thank you.
Mm-hmm.
All right, now I'm just going to go down the list to make sure that I've asked everybody. And Amy Nutman, I'm sorry, but you're on the top of my list.
One that comes to my mind is Meals on Wheels.
All right. And Becca just went. So Diane, I'm not going to skip you. So go, if you have anything, go ahead, Diane.
I mean, given our role in multi-pair coordination, I'd say the Shires, the existing community health organizations, and the Detroit, you know, and Alex's group with United Way are the closest parallels that we would have to offer.
Awesome. Joseph.
Sorry, unmute myself. I'll send you an email with a more comprehensive list. We have a lot.
Okay.
But I mean,
that would be great.
With several that have already been.
Yeah, if anybody wants to send me a list after this, feel free, and we would be grateful. Lindsay West.
So we're unique because we are more coordination for the POs and practices and not so much with the community partners piece. I mean, we've done some alignment with MDHHS, but in terms of I guess what we do quite a bit is through our webinar content. And again, that's quite a comprehensive list that we actually enlist community partners through that way to then provide resources and education. So, I mean, that's probably, and again, that is very expansive. But I'm happy to send some information on that too.
All right, thank you. And there are people popping up higher on the list than I've already gone, but I'll try to come back. Dr. Klinkman, you're going to have a voice here as it relates to what you do in your clinical setting. What community partners do you work with?
Oh boy, where do you start? Area agencies on aging, of course, is pretty high on the list. But beyond that, I often work directly with senior centers. I have a lot of older patients in my population, so I'll lay those two out.
Thanks. Pam.
So we also are a physician organization. So for us, it would be, it's a very long, extensive list. I think I would also agree that we'll just have to send an email and kind of get an idea of what the providers are using
Okay,
or practices, I guess.
I would appreciate that. And again, we're asking this question because we want to do outreach to those organizations to see if they have thoughts and feedback for anything related to MiHIN. Rachel Riley.
Hi. So we are also a PO. So we actually surveyed a lot of our practices that belong to our PO to see locally, because we're so spread out in the UP, what kind of resources that they utilize on a regular basis. We see a lot of community action agencies, senior centers. One that we have up here is Great Lakes Recovery Centers for substance use and abuse. We have quite a few of those across the UP, and they get utilized quite regularly.
Cool, thanks. Sharon.
Morning. So we are a physician organization as well. And I would say area agency on aging for sure. We've done some of this work trying to do the closed loop referrals with a handful of community partners, and we were not able to get that off the ground. But I can put a list together and email it as well, because we're 5 counties, so we have resources kind of everywhere.
Yeah, thanks. Shlomo.
We're not currently using any particular community organizations.
Okay, thank you. Now I'm going to try to go back through and get the people I missed. Alex.
Hi, good morning. Yeah, Henry Ford throughout the Metro Detroit and then into the Jackson area regions work with a ton of community partners, from the 2-in-1 connection that's out in Jackson, the community care hub, which has got a really robust network of partners, into Detroit, where we're working with all kinds of organizations. From Food Bank and Gleaners, Community Food Bank is a huge one. A lot of food partners, some different housing organizations, a lot of organizations serving women and children through our WIN network, our Women's Inspired Neighborhood Network, focused on maternal and infant mortality. So really big diversity of organizations.
Awesome, thanks. Alicia.
Good morning. This is Alicia Meyer from Michigan Medicine, and we are currently using Aunt Bertha or Find Help, or we're implementing it as we speak, basically by the end of the summer, hopefully to be live by August. And we've been working with a lot of our larger area community or partners, such as Food Gatherers, Jewish Family Services, Area Agency on Aging, many of the organizations that were part of the Shire with SIM, and trying to figure out how we can figure out some kind of closed loop with Find Help. Trinity Health has been a huge partner with us on that work.
Awesome. Ellen. All right. We have a dial-in caller, and I'm not sure who that is, but if you work with any community partners, we're interested in finding out who those are, whether that's at a specific level or broad level. Looks like you unmuted in Zoom, but we can't hear you. Thanks, Ellen. All right. And there was one person whom just joined, but I don't. Oh, Marissa. And Marissa, I apologize. I'm going to put you on the spot. But this is the one question that I'm going through one by one and asking people if they would describe kind of who and where the community they engage with is.
Like where I'm located?
Yeah.
Oh, Lansing, East Lansing. I work for Michigan State University Healthcare.
Okay. And are there community-based organizations that your organization works with that it would be appropriate for MiHIN to reach out to get feedback about plans and they could have a voice in our roadmap?
I would have to think about that, but I can get you a list.
Sure.
Okay.
That sounds great.
Thank you.
All right. So for the remaining questions, I don't plan on going through people, but I assume you're all here because you want to be here and have opinions. So I'm going to start off by asking, and if you weren't here last week, I apologize. As brief as I can, our thoughts on referrals are that there are a bunch of different social referral networks within Michigan, and especially where they overlap in geography, there needs to be some sort of broker of referrals, so that way two different organizations that use two different vendors aren't stuck unable to make a referral to each other. And with that in mind, hopefully those that were here can provide some more feedback. But what did I get wrong about the problem statement that we're like, what do we need to know about that we're not even thinking about in that problem statement?
This is Alicia. I think the problem statement sounds right. I think it's just going to be sort of the devil's in the details as we start figuring out how to use it.
Okay.
I do agree that, if as Michigan medicine is statewide, I'm sure that there are other organizations using other types of technology, and it would be great to be able to see what people have been referred to from other technologies so that we can either know that those worked or didn't work and, repeat the referral or do something else. And having that knowledge is helpful when you're trying to figure out what to do to help a patient get the connections they need.
So this is Sharon. So we spent a lot of time building our community database, like I said, to cover the 5 counties that we're in. And some of the challenges that we had were, some of the smaller counties, St. Clair, where there's specific resources and, really trying to figure out what those resources were. And honestly, we had to get a lot of people involved, including our social workers from a lot of our practices and things like that, just so that we could really find out what the resources were that we really needed. And, because there's a lot of resources, but there are people who know which resources are the go-to resources. So I think that's something that we should consider too, especially as we're looking at a large area and, that may or may not have a ton of resources.
Cool. Last thoughts, opportunity to say, MiHIN, you totally missed the point.
Well, I don't think you totally missed the point, but I think the point is people do have other resources they're using. And how do we connect them all? Do we want to connect them? And, you know, and what do those players look like? I mean, are they gonna want to be connected? So I don't think that you missed the point. I think it's just that, you know, there's a lot of work being done out there, and how do we take advantage of the work that's being done?
Perfect. I wanted to start with this question in this realm of topic, just to make sure I wasn't starting with the false assumption, but we'll keep digging more and more as the questions get deeper and deeper. So I identified these 3 paths in the presentation. I said, option 1 is we do nothing, and no one's exchanging across platforms at all. Option 2 is everybody uses the same vendor, which my assumption is that's not realistic. And the third option is that there is a broker that is facilitating across those referrals. Is there another option, or is there a solution that you've seen already to address that?
And Mike, just to clarify, the broker facilitating across organizations would be, for example, like a network of networks, like MiHIN
Right.
ingesting the information. Is that right in terms of interpretation? Okay.
In relationship to this question, this is Amy. I know we talked about My 211 and what United Way is doing. Do we have, I mean, when you talk about, is there already a solution out there? How much do we know about how much they're doing this?
I believe that we have somebody from Henry Ford on. They were one of the 2 main pilots that 211 had told us about. I don't know if the person from Henry Ford wants to talk about what they're doing with 211.
Hi, this is Alex Plum at Henry Ford. We have a couple different partnerships. In Jackson, as part of the original Shire, the Community Health Improvement Regions, Jackson Allegiance and their 211 partnered together with several community-based organizations to create what today is the Jackson Care Hub, which is an integrated model of closed loop referrals addressing the social determinants of health for patients and members of the community in sort of a completely integrated network. So it's got health system partners, healthcare providers, and then a whole suite of CBOs working on all manner of things, skilled nursing, all the way to social services. In the Metro Detroit area, Henry Ford Wyandotte Hospital and several of our downriver Henry Ford medical centers are partnered with United Way for Southeastern Michigan to serve as a hub to connect food insecure patients directly to Fish and Loaves Community Food Pantry. And we're working right now on expanding that work, both geographically into Detroit and Dearborn and Hamtramck, as well as beyond just food insecurity to additional SDoH domains. And in that area, in that example, 211's call center, their social health navigators are sort of taking on the role that our current case managers play in doing the deeper assessment for SDoH vulnerabilities and then playing that connection role.
Thanks. So to answer the original question, the 2 pilots, I can't remember who the other one was that wasn't Henry Ford, but that's what I'm aware of, that United Way and therefore indirectly 211 are working on right now, as far as beyond just being a resource directory. Are there more thoughts on this question before we move on? All right. So assuming that we all agreed on the problem statement and that there should be some sort of a referral broker between these vendors, our proposal was, our general stance is that Michigan 211 is something that's had multiple millions of dollars, many millions of dollars invested in from the state of Michigan. They already have a higher level of resource directory than I think others have. They're relatively vendor neutral. And so from our standpoint, they make sense to be a common resource directory. And let me, I know I said I wasn't going to talk this whole time. The reason that a common resource directory is necessary is that if you're part of a referral network and you have your own resource directory, you wouldn't be able to refer to somebody outside of your network because you don't know they exist unless we have a common resource directory for everyone on all the networks. So is there an approach that anyone would recommend other than us pointing towards 211?
Do you mean everyone just using 211? Because I guess we're going to use Find Help, not 211.
Okay, that's fair. The way I imagine this working, which is not completely fleshed out. We're still in conversations with 211. We're still in conversations with Find Help and Unite Us and others. But the way I imagine this working is when you go to make a referral, we would work with the vendors essentially to be able to search for things that 211 has outside of whatever 211 has in their directory. Or if Find Help has everything in their directory, 211 would still be the ultimate source of truth that we're telling people to keep updated. And that would have the ability to flow down to other directories.
Mike, this is Mike Klinkman. Is it okay if I jump in here? Because
yeah, absolutely.
I think Elisa's question is a really important question and it's really nuanced. And I want to make sure that everybody has a chance to hear this and then push back or digest it. And I want to make sure that we digest it really well. What we're talking about in this 211 conversation is the idea of a resource directory that is clear, that is coded, that is standardized, so that we know that agency A in community X is this agency with this capacity, with this code saying that this agency is what it is, so that whenever that agency performs a service or whenever that agency is referred to, you know that that is the agency that either did the work or passed it on to somebody else. It's the idea of on the medical side, it's the idea of a provider or a practice that is identified so that you know who has done that work. The reason why a common and standardized and coded resource directory is important is in the long run, you need to know who has done what, because we are going to be faced with multiple changes in how this work gets funded and resourced. If you have in every community's own bespoke handmade resource directory, if you don't have that information in a way that other communities understand that same information about that same resource, you cannot do an interoperable referral because you won't know where it's going exactly. And you cannot identify who did what because you won't have a code for that. It's like having 30 to 40 to 50 different internal telephone exchanges with numbers to get to your friends and your neighbors, but everybody has their own personalized one, but everybody's number changes in another directory. So the important thing here isn't that you're using a platform, Find Help or Unite Us. If you're going to be able to communicate with another platform, you're going to need to have a shared directory on each end so that you can land a referral where it needs to be landed. So if you are Find Help and you're working in the Grand Rapids community and you send out a referral, as long as somebody else is in your Find Help ecosystem and build, that might work. But if you are a small housing-based narrow network in Grand Rapids that uses Signify Health's platform, it can't land because their resource directory is different. So regardless of how many platforms are in use in your community or your region, you're probably going to need to have a common phone book, a common directory to work from. Is that, that's a lot of words, I know, but I just wanted everybody to kind of get a chance to digest that, come back, because that common directory is one of the key building blocks to make this work scalable, even, Alicia, within the Washtenaw community, because there are at least 3 different platforms currently in use in Washtenaw.
Right.
So you can't do it with your homegrown find help directory if somebody is using a PCE directory that's different, or if somebody's using a Washtenaw Community Care Hub directory that's different.
I think I need to understand, like, I understand the idea of a common directory. I'm just trying to also understand, maybe I should just listen more, because I think that I think the reason why people are choosing various directories is because of their strengths in their areas also. And
Yes.
so I understand that idea, and I think I just need to listen more to figure out like how this would work, and how it would be beneficial in actuality versus in theory. Because I think I understand the theory. I think it's just when it gets to some of the practical side that it gets a little bit more muddy.
Well, I'll anticipate some of that. So the current status of a statewide 211 resource directory is it's as good as the resources that the state has put into 211's assembling it. There are missing pieces still, and there are especially the piece for capacity of an agency that has never been implemented. And that's really important. And that's one of the customized things that we already heard in this conversation, is we need to know who wants to work with us, who has capacity to work with us. That has not been part of the build to this point, but it's part of what we're discussing for the next level of work here. The second thing is that if we all, meaning everybody who is doing this work, every one of the shires, every one of the other groups that are building community exchanges, agrees that we want to make a shared resource directory the best possible, then they will collaborate better, or can collaborate better, to make additions to that common resource directory so that they better reflect the conditions in the community. And that can be fed back into the process that 211 has used to make their directories better, so that everybody gets a better, very useful directory out of this that you can all work from. There's no way to ever cut out the custom wired in things that people have in their heads about who their go-to pals are on the community side. That'll happen no matter what. But if you have a directory entry that can catch them, and that can tag them, and that in the process of a referral being exchanged and services provided, that tag team can then be routed back to close a loop. That's the function that the directory makes much easier when you're moving beyond just your own internal small network with your provider vendor. So this is going to be a ride, folks, as we talk about this, because it isn't here now. It's important for the future. And we want a lot of pushback on this from the practical side. So, you know, aside from Alicia, we want everybody to talk to us about this if it feels like it's a too far a reach.
Well, I think building on what Alicia was saying is, so again, you know, when you're looking at building a community database. So if we're looking at, you know, the larger organizations, the ones that, you know, would have a lot of capacity or could, you know, potentially, you know, provide these closed loop referrals easily, you know, that's one thing. But when we're talking about kind of the nitty gritty or the, you know, the small resources that might be specific to an area, I think that's a different topic. And
absolutely.
And I'm not sure that any one hub or any one database is going to be able to capture all the nuances of every community. So I kind of I feel the same way that, there are challenges. So maybe for some of the larger organizations, but I still think there's going to be, like the small transportation provider in Romeo who everybody knows, and it's not necessarily like, I'm not sure who's going to have the time to update that routinely based on, I guess maybe I'm not sure exactly how it's going to work either. And maybe I'm not seeing the larger vision, but those are just the things that I see.
Sharon, those are great comments. I think this is Mike again. I'll respond to that one. We know that there is a sort of a boundary or a place where a local food pantry or the equivalent of John Smith, who does transportation for seniors in Chelsea on Tuesday and Thursday, is not going to be in a broad statewide common resource directory with the entries that we talked about. And what's evolving as we talk about this a lot, both in Michigan and elsewhere, is that there are other ways to handle that part of the traffic. But one of the things that you will need to be able to do if you're a small agency in the future may be to identify that you have provided this service. And that can be done with some simpler technology than we're talking about here. So yeah, point taken. Every entity, every person, every small volunteer group that does community work will not be in a statewide resource directory. But I think that the bulk of the message traffic, just like the bulk of medical message traffic, can be greatly facilitated if we do have a core that everybody uses. And it's just at the margins that we will have to work together to figure it out. So good pushback point.
The other thing I'd just like to add is when Eva made the comment at the last meeting about not working in silos and being able to work and hear what the the CBOs are saying and some of these other groups. And I think that would be really important, to hear what their challenges are or what they see as a vision as well. So I would think it would be a really good idea to bring the groups together at some point so that we could better understand everybody's vision and, where we think this could go, because you might gain synergy that way with the groups.
Yeah, this is Mike again, absolutely. And what we're trying to do in conversations like the ones we're having with this small group now, and the conversations that we expect we will have with a group of community organizations, are walk them through these same issues so that we can help them to articulate and we can better understand how they're working. And that should make the conversation across the silos a lot more productive. At least that's our thinking. So they're going to be doing answers to questions very similar to what you guys are seeing right now. Sorry, Mike T, back to you.
I'm making an ad hoc drawing really quickly here. But why is it not showing the whole picture? All right, well, I guess I'm just going to show this in Visio. I'm going to stop sharing this real quick. But what I'm trying to illustrate is that one way or another, there's a decision point to make. There's Visio. So here's vendor 1 and they have their own resource directory. Here's vendor 2 and they have their own resource directory. And let's just say that both of them are perfect and they both know about this community-based organization and they both know all the services and where they provide it. There's not a problem with the resource directory from that standpoint. But let's say this particular community-based organization uses vendor 1. Let's say this is Healthify, and this is Find Help, and Alicia, her group uses Find Help, so they know CBOX exists, but they can't make a referral to them because they use vendor 1 unless we have this broker in the middle and vendor 2 knows that they use this other, they have to know that they use this other vendor, vendor 1, so that there can be a handoff to that organization through that vendor. And Find Help directory isn't going to know what vendor this community-based organization uses unless there's a common directory that's disseminating that information out. So even if we're not talking about knowing the organization exists, there still needs to be some sort of common directory that says this community-based organization gets their referrals here, this organization gets their referrals here, this organization gets their referrals here. And so there has to be some sort of common directory from that perspective. Or the only other option I could think of, which is the example I put on my slide, I'll go back to my slides now. The only alternative I could think of is a federated directory, which would be like all the Find Help registers its directory and all of its users to some MiHIN thing, and Healthify registers its users to this thing, and somehow they can query each other through a federation. But that may be viable, but it also may be a different amount of work.
Yeah, as it scales, it becomes not just incrementally, but exponentially more work to make sure that the federation directory links get maintained. And that would be a much more expensive solution for the state, for each of the regions in terms of being able to exchange information, and eventually may collapse under its own weight. I think the value of a core directory that's one directory that has a common listing that everybody moves to is that most of the work of federation is then simplified because there's that core reference point for everybody. And then you build out your local community uniqueness or the nuanced stuff and use that as the supplement that you need. That kind of gets back to Sharon and Alicia's point earlier.
All right, I think we've probably beaten this one to death for the day. We'll have more conversations in the future, I'm sure. All right, so from your organization's perspective, does the format of the actual payload of a referral matter? Meaning, from a technology standpoint, does your organization need to be ready for FHIR, to use FHIR, or any of these other standards? I listed all the ones I could think of that have a referral standard. Or is it the vendor that you would have to care about that, and your organization is indifferent?
So this is Pam, and I work for a physician organization. I would say we have so many different practices. I could be, because I am fairly new to all of this, but I would think that it would be very different for each practice. So I don't know that there would be one format. And again, I'm fairly new to doing this, so
sure.
I'm thinking,
I guess what I mean is, if you're using Find Help to make social referrals, you probably don't care what format the exchange is in, because when you log in, you just want to see the referral. But if you are bringing a referral into your own technology platform that you've built, that probably matters more to you. And
yeah,
so,
I don't know that I can speak to that right now.
Okay.
So this is Mike K again. Maybe a way to frame this question in a way that makes more sense to the medical folks in the in the audience is, how do you handle referrals for other medical services now? Is it all done inside the envelope of your electronic health record? And are you like me in that you have different formats in terms of the user interface for what you have to complete as a clinician to send off a referral? That's one sort of format question, is what information does the person receiving the referral requesting? And how onerous is it for you as the person initiating the referral to send it? That's one whole sort of format set of questions. But the second one is, how do you get a referral from Michigan Medicine to, oh, I don't know, to Henry Ford Health System that's in Epic, into a practice in the community that does behavioral health care that doesn't participate in your electronic health record, or a practitioner who's a really great neurologist from my family practice standpoint, who's an independent physician who isn't in the Epic environment. There are two different types of questions, and what does your neurologist friend need from you, and how do you get information back from him that is close enough to your workflow that it's useful when you make those referrals? We're trying to figure out how to make a social care referral easier, and trying to figure out if there's a standard way to do that the way we've done most of our work on the medical side, knowing that everybody just can't sign into Epic. I mean, that's where we started this about 5 years ago. Everybody, Epic thought that they could just do all this work, and it turns out that they can't. So how do we figure out what to send out and what we need to get back? And for those who are more technically savvy or are working with the technology of their vendors in the community referral platforms, do you have, or does that vendor have a format that they are expecting that they will use to move these messages?
This is Becca Fleming with Packard Health. So we're a federally qualified health clinic, right, based in Washtenaw County. And I guess I'm a little caught up on this idea of a referral to various organizations. And maybe I'm misunderstanding your question. But for example, we work closely with Michigan Medicine, of course. We have an MAT program at Packard. So in Michigan Medicine, for example, someone presents to the emergency room, needs follow-up MAT services. It's a phone call. I mean, there's no, right now we use different EMRs. There's no platform. I mean, it just doesn't exist. So I think the majority, when you taken literally, referrals majority of ours are phone calls.
Yeah, and that's what is easiest and most simple for the sort of real on the ground care connections to this day. Work I've done in other states, we worked with communities and the community's leadership and governance to try to figure out what and how to replace that idea of a phone call, because a phone call's not trackable, countable, and trying to figure out what demand for services is becomes much different when you can't track what the demand was. And this is a sort of a first wave of trying to quantify how to make those connections more explicit and countable, and to learn whether the connections worked or not. Mm-hmm. So Beck, if you could imagine, instead of getting a phone call, the emergency department sent, or a referring clinician sent a simple electronic message that you could take into your system and have it in a queue when you came in on Tuesday morning, mm-hmm. or these referrals for MAT came in yesterday. And then that's exactly the case that Alex was talking about, the Jackson ecosystem, and that's exactly the case. We built that out about as far as we can right now in Jackson, to try to move information between medical settings and community settings back and forth, not just one direction from a medical practice sending a referral for transportation, but from a community action agency seeing a client who needs healthcare and getting a referral back into the healthcare system. And those little tickets can go back and forth so that we know what the demand is, and we know if we're not meeting the needs, where the problems might lie in that chain.
Yep,
So-
I got you. That makes so much sense. I completely hear you. Yeah.
Okay, so this
Thank
can
you.
be a very simple thing. It can just be a, hey, you, please do this. And let me know when you did it. Or it can be a lot of other stuff that we tend to put in much of our referrals within Michigan Medicine now, which is, how old is this patient? How many other risk factors do they have?
Yep.
You know, blah, 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 blah. Okay. So I guess we're going to take away from this, Mike, that the format doesn't much matter to anybody as long as the messages get exchanged.
I'm not sure that, and I know there was a comment last meeting to it, just because some of us aren't answering, I don't have an answer to that question. So I would have to take that back and find out what the preferred format would be. So
Okay,
I can't really provide you information right now on that.
I'll send this presentation out to the group at the end of this call. And if there are things that anybody feels that they could get a better answer by taking back to the organization, I would really love it if you would send us a reply afterward. And we'll make sure your feedback is taken into account.
And this is Mike. Can I break in one more time, folks? Please don't feel like we're haranguing you with questions that you don't care about. We have been thinking about nothing other than these things for many, many, many months. And so we're just trying to help translate some of the questions that we're struggling with. And there's a huge gap there because most of you haven't had to engage in this work. So it's not, so we know it's unfair. We're just trying to help you to start thinking about this and getting your first reactions to stuff to say, hey, what's all this about? And why on earth are you thinking about this stuff? So hold us to the fire if what we're saying doesn't make sense. Hold us to the fire. I think, Sharon and Alicia have been really good at holding us to the fire in this call, so keep it up.
All right, so in obvious but full disclosure, the first part of this question is a loaded question. But are you concerned about, as we start talking about this technology side of things and not just having a phone call, are you concerned about putting expectations on these community partners and the people who receive deferrals, and if they're not getting any compensation for taking on new activities? And if you are concerned about that, do you have any ideas on how they could be compensated, or what model could exist that makes them whole and happy to be helping in this way?
This is Diane, Mike, and I'm just wondering, in other examples, like in the Jackson example, how was that accommodated in terms of engaging the support of social referral receivers and the cost of their work?
Yeah. So Mike T, Diane, this is Mike Klinkman. I can jump in and answer that because I was there when we built that network. That came out of a community ethic that had already been established. So in Jackson, there was an existing community health improvement organization that was that had a broad range of participants from the community, from business, that had done a good job already of seeding a collective impact model for their community. And the community's expectation of itself was that the leaders and the community organizations that were participating did this from a community spirit, community volunteer basis. So it was expected that they would not be compensated for work they were doing to try to make their community a better place to live and work and raise children. So that was pretty enlightened, and it's pretty rare. I've worked with a lot of communities, and that was kind of the most fertile starting point I'd seen. But when we started to build what became the Jackson Care Hub for SIM, we put about 18 months of work into meetings that had any number of large to small community-based organizations, the healthcare system and some business leaders who met weekly to bi-weekly, mostly weekly, to figure out a common care model for the community that they could participate in. And the goal was not for those agencies to receive compensation for referrals. It was to try to make a system that reduced their overhead of work. And what we were able to do is get the large group of community organizations to see that this saved an immense amount of work in terms of telephone calls and missed calls and trying to track and duplication of services and community action agency providing services that area agency on aging was providing, but they didn't know about. So when we built a hub that the agencies working with Mr. Jones, the patient or client, could see the work that was being done, they have stuck with this model over now some years because they see that it reduces a lot of work that was not productive. Extending it to smaller community-based organizations has been challenging because they were not as engaged in multiple services for the same person if you're just a food bank giving somebody a package. So that's why we keep looking back at Jackson to say, as we get to the issues that affect smaller organizations, we get past a core of the bulk of the work in the community, there probably need to be different models for connection and for compensation. And long-term, the survival of a network like the Jackson Health Network and the Jackson Community Care Network and the Hub depends upon there being enough financial support to maintain and expand their services, to be able to fully bring in and implement MiHIN's standards that vendor has pledged to meet, so that they can be a participant in a broader state network at a point at which one exists. So the compensation comes in because the work will get harder. The demand has been harder with COVID. Referrals got backed up in Jackson as we tracked it. And so the compensation so far has been, they're learning so much about how to work more effectively that it's been worth it. But at some point, there's going to need to be some infusion of support into the system to sustain it. Does that make sense? And the conversations are now starting to look like, hey, you're asking us to do all this extra work. We're getting many more referrals. We're having to work our staff harder. The staff is swamped. Is there any help here, please? And you're doing this so that you can keep people out of your emergency room and save money in your healthcare system. Can some of that be circled back to us through community benefit or some other means? So Diane, long-winded answer. Yep. That was the question?
It does. It helps a lot, Mike. And I'm, every margin must fund mission, right? for everyone. Have you seen creative or interesting ways that groups, folks coming together have addressed this nationally, or any lessons to take from that, or is it sounds like a something that everybody's tackling together. No one can provide services pro bono forever, or few can.
Yeah, there are lots of models that we could probably talk about in a future session. I'd love to hear some of our folks on the line just figuring how they're starting to think about this expectation compensation issue, because we have our own view at MiHIN that's partly coming from national exposure, but I'd love to hear where you're at locally too, so we know how to start to work to bring people together across Michigan.
Yeah, this is Joe from Midstate. I just had a question, and just the compensation cost. What if these small social service providers don't have electronic means to even receive the referral electronically in the system, and all they can get is a phone call? I mean, there's a cost associated with that up front that they may not be able to do.
Yeah, and this is Mike Kagan. This is there are different ways that's been handled. Some vendors have marketed to healthcare organizations saying, why don't you buy this software? That's what Find Help and Unitas have largely done. And then it is offered to community partners at no cost. There's a hidden cost there because many of these connections are a one-to-one connection, not a distributed network connection, so that if you sign on as a local, food resource or a local transportation agency, you sign on only to be able to communicate back to that healthcare system that provided you with the software. And the interoperability isn't there yet. So it's been very, very hard. We've had lots of stories from community organizations who have been approached by some vendors working on behalf of payers or provider organizations that say, we don't even know how to evaluate these opportunities because they don't understand the difference between joining a distributed network that lets them connect to the broad community, as in a full community information exchange, or just being able to connect back to the benevolent healthcare system in my community that has, linked me electronically. And we are, in the workshops we ran earlier this year, we had examples from community organizations being approached by up to 4 to 5 different vendors in healthcare systems to sign on to 4 to 5 different platforms that did not communicate with each other. And we're trying wherever possible to prevent that. It's just totally disheartening for a community organization to feel like their future lies in committing to things that they don't even understand the implications of. So where possible, we'd like organizations not to sign on to things until they have a better understanding of whether there is a local network that works for them, and trying to find a way that it holds them harmless in terms of cost. Nationally, we're talking about very simple stuff. A smartphone connection for a staff member that can just say, hey, got this referral, sending back, it's done. I gave this food bank this food delivery to Mr. Jones. And we will also know that there are going to be some that are still just going to be faxed or phone calls. We're not going to catch everything. And we just don't want the last thing. I'm a family doc. The last thing that we want to build is a system that will collapse under its own weight because it has to accommodate every possible nuance. So we're trying to get this generally right at the first stage so that it can scale as much as it can scale. But what we know more than anything else is that we don't want to double, triple, or quadruple the work that community organizations have to do to participate. Okay, end of rant, off soapbox. Did that answer the question, Joe? I hope.
Yeah, thank you.
This is Alex Plum. I was going to go back to Diane's question. Upper New York, there's a consortium of organizations working together that have figured out a kind of creative way to do financing. I can't remember, Len Nichols, I think is the man's name who came up with that model. The 2-on-1 example in San Diego is another one that's pretty rigorous, and they've got a pretty good financing model. I'll just say from the health system perspective, we're still trying to figure out how to attribute the return on these kinds of programs so that we can understand how connecting a patient to closed loop resources like this does impact or influence in the short term utilization, and then in the longer term things like cost of care, and in the longest term, sustainable improvements in disease management, healthy weight, A1C, blood pressure, you name it, and then trying to actuarially assign a value to that. The truth is, with the advent of value-based care, community organizations are not dumb, and they know that we have that we're getting capitated arrangements to take care of whole person health, right, for patients. And so they're like, okay, well, if you're going to ask, us to stand in the gap and address these social barriers, then we want a cut of that. And I think that's the right question. The problem is we don't have sophisticated analytics sophisticated enough models, at least, to be able to attribute to these interventions right now what that return is. We're seeing in our food program, for example, pretty significant utilization reductions. But as we connect patients to gleaners, they get food delivered for a year. And then the within group differences and between group differences for the patients that receive this are pretty significant. But then when you start controlling for all the noise, you see that the folks that you're serving are, already typically pretty sick, and they're already getting a lot of other services. They're getting integrated case management support. They're getting mobile paramedicine to their home. They're getting diabetes coaching. They're getting all these other services. And so then all of a sudden, to start taking all the noise out and controlling it, you need such an expansive sample size that you quickly you realize that your numbers are too small to detect an effect change. So it's hard. It's really hard. And so we're getting these capitated payments, and we don't know what percentage has to go out, but we've got the community partners saying, we know that you've got the money, share it with us. For me, it's a reminder that the health systems are one part of this. We do have a lot of the resources. We do need to be able to provide that to social service organizations. But at the end of the day, so do payers. And payers need to be thinking creatively like they do in North Carolina, where as part of their Medicaid waiver, they're able in North Carolina to pay CBOs directly to address some of these issues for their patients, for their members. And then that way they're sort of cutting out healthcare. So I think, we have to think really expansively like this, and we have to be working with payers, and we have to be working with MDHHS to kind of help create that. But I just wanted to say that, like, we reference value-based payments in these terms like it's a panacea, and I think one day it could be, but it's really, the evidence is so scant right now, and I'm just living in that tension.
So this is Mike K. I'll make a suggestion to the group, Alex. That was great examples. And I think that will be one of the focal points of trying to bring community organizations and providers together once we have gone through these sessions. And that's kind of been our plan right along in getting our MDHHS colleagues who are working on SDoH and health equity issues in those sessions. It's going to take a lot of thought and creativity to figure out some kind of braided support. It won't be one full solution anywhere. But I think that moving to that, I think will help to make implementation of community information exchange easier. If people have some degree of trust that there would be a way to handle these compensation issues. So this has been a great discussion, and we're taking a lot away from this part, especially.
Yeah. Whether we're talking about from the healthcare system or from the payers directly, the one thing that I wanted to surface is that I don't necessarily have the ideal model in my head already, but and in fact, a fee-for-service model may be the way things have to get started. I'm not sure, but just wanted to point out that if we start compensating CBOs for the referrals they receive, we have to be careful not to start taking the same burden that was a fee-for-service system that we put in healthcare onto the CBOs and try to realize that that model itself has its own cost. All right, we'll move on to the next question. Thank you, everybody, for your participation. So we're not talking about when a patient has a need and you try to refer them somewhere and they say no. But what scenarios are there when a patient would be referred to a social or human service, but there's not really an actual referral needed? Like, the thing that always comes back to me is we use food banks as an example a lot. And the food banks that I'm familiar with don't require a referral to go get food. Not saying that you talking to the patient about it isn't going to get them there. And we definitely are trying to support a closed loop system, but are there scenarios where that closed loop is more work than it's worth? Or is it always worth it to try to get that closed loop?
Well, I would think there's absolutely scenarios, and although I'm not sure I can come up with them right now, but I'm sure there's got to be scenarios where don't need that closed loop. Like you said, a food pantry, an organization, a church where you're getting clothing or something that, yeah, I don't know what they are, but I'm sure that there are.
And I guess my motivation for asking the question was tying back to the last one about compensation. Is there any ramification to them, or, I mean, their organizations exist to provide that service?
Well, I think when we're even talking about the compensation, I think this goes back to kind of where my thoughts are is the big organizations are kind of one thing, and then the small community organizations are another.
Mhm.
And are we isolating those small organizations, the ones, like you said, maybe we don't have to do a formal referral to, or maybe they're never going to have the ability to do a closed loop referral, and does that put them at some kind of risk? Or is there an area, is this specific to, geography where, it might not be feasible for that to happen?
Yeah, Sharon, I really agree with that. This is Becca. And I think to the prior point about really, community groups who are doing that. So for example, your example regarding getting clothing at a church, a lot of that is volunteer run, things like that, right? We get DME equipment from a church every day, basically, and they're fantastic, but that closed loop isn't really necessary yet. Those are always going to be where folks go, right? So I think that's the bigger question at play too.
Hi, it's Amy. I also think there's also what I consider on the edge people. So they're not formally in that need, but either it's anticipated or they're not quite there yet. And so, you provide them information, but it's not a formal referral. It's like, okay, well, if X happens, then here's your resources, but then it's not really a formal referral.
So what responsibility do we have if we're talking about compensating organizations? If there's some organizations that have a burden put on them to close a loop in a referral system, and others that we're just saying, hey, go here and they'll help get you some clothes. Is there any sort of responsibility to make whatever the compensation model is apply to everybody? Or is it okay that it would be, we're putting burden on these organizations so they would be compensated? Or is it, just how do we frame that conversation? We'll definitely be having a similar conversation with the community groups themselves, but I'm just trying to spark.
So this is Mike K. Let me ask the question in a slightly different way too. Maybe that'll get people's heads moving in a different direction. If you have been working to start a network in your community, or you've been working with community organizations, my guess is that you've started by picking the organizations that you think are most important to join up with or to partner with. And why did you pick those? Is it because you felt like you really needed to track the process of care for those conditions that those organizations can help you with? So is it based upon your need for information to know whether these sort of big ticket social problems are addressed? Is it just that they happen to be already existing partners that you could pilot this with? Or were you kind of in your minds thinking, it's really important for us to connect to these kind of like 7 or 8 different major groups in our community, because we really do need to track traffic there for a lot of reasons. But for the other 123 small organizations. It's not so important. We'll get the ones that really matter. Has that been some of the thinking as you started this work?
This is Rachel Riley at UPHD. Sometimes, depending on our location up here in the county, they can be extremely rural. So a lot of times it's dependent on just the resource itself, because we may only have one resource for food in that area or such. Very limited.
So that's the any willing partner approach and any available willing partner approach. Yeah, that makes sense in areas that are more rural and scattered.
This is Becca Fleming. I would say ours, we go to folks who we've built relationships with and who get the job done, right? They know our clients, they're dependable. We do kind of have a go-to contact at these various agencies. So it's almost kind of the why not. We already know them, they know us, and they get it done.
Thanks. Anyone else with thoughts? All right. So we've gone through a bunch of topics, and I do have, I think, 3 more after this one, but I wanted to make sure before we got to 10:30, I asked, after having delved into some of these conversations, some of these topics, like the need for a broker of some type, what are your thoughts about it being MiHIN's role moving forward, trying to be that broker? Is that something that makes sense to you, or not? I'm not trying to get something that I can throw somebody under the bus with later. I'm trying to earnestly be able to say, this is something that people see value in MiHIN taking on, versus if everyone's like, I don't know why MiHIN's doing this, then we could direct our efforts somewhere else.
This is Alicia. I do think that there's a lot of merit in what you're all working on. And I appreciate the effort to think through how do we make this work really well and have it be easy for everyone. Like, how do we make it be easy for the community organizations to keep their information updated and make it just a standardized process? Like, I can see that working really, really well. I think it's just sort of thinking through it all and figuring out how to pivot our plans so that we're taking into account, the upstream and downstream effects of our work, so that it's more effective overall. So I do appreciate you working on this, and I do think that the interoperable referrals, it does make sense to me. Like it's sort of like the problem with all of the different portals. A patient has 100 different portals. You don't want the CBOs to have the same problem, or even us to kind of try to sift through what's going on as POs or health systems. So I do appreciate it.
Cool, thank you. Anyone else?
maybe, thumbs up, thumbs down in the chat or by the icons for each of you, just getting a sense of whether, even if this doesn't seem like it's directly affecting you all yet, does this concept seem like it's worth pursuing, or should we let things evolve as they are currently evolving?
Thanks, Lindsay. All right, I guess I'll stop dwelling on this one. All right, so here's the last three kind of prodding questions I had. I didn't know where we were going to be with time on this, but there's definitely there's a very different connotation between making a medical referral to making a referral for someone's social needs, and so the question is, do you, on a technical level, in addition to a business level, see a need to differentiate that, especially when it comes to what data you need to pass? So Dr. Klinkman was talking earlier about how Michigan Medicine wants to say, how old is the patient and all these different factors. Should social referrals be a different model?
So I wonder if that's part of like so we hear a lot back from Michigan Medicine that we don't send the right information to the CBOs. And so while I agree that there might be different information that they need, it might be important to get that sort of common denominator and what is the wild card in there for different groups, because that was one of their complaints back to us as we started to talk to them more.
Got it.
I don't know if that's answering your question at all.
That definitely helps. So whether or not it's more or not, it's different. All right. Given that it's 10:23, I'm just going to ask the last one, and then we'll start talking about the next session. So the last question I have is, okay, so we have this referral brokering tool solution set up. Everything works. We're in a utopian referral society, and now we have the technical capability to notify other people that this referral was completed. Is that something that we want to do? An example would be, you're in the emergency room, the emergency room person finds out this person has social need, makes a referral, and we notify the primary care physician that they got this need met through this referral at this organization.
I think that's the whole idea of closing the loop, and I feel like that would be really wonderful.
Yeah, I completely agree. I think this is, having this closed loop system, but also, not to duplicate efforts. SDoH needs are such a reason for high ED utilization, like it's such a bigger picture. So I would absolutely agree with that.
All right. Got a lot of positive feedback in the chat also on that one. All right, it is 10:25. The next session, we're going to send out another poll to try to find the right date. But the next session we're planning on covering is going to go over Z codes and social diagnosis. Z codes being the diagnosis codes that are used for social needs that have been identified. They're sort of an informal set of ICD-10 codes. Does anyone have anything to, any outstanding questions, anything you want to talk about before we end today?
This is Mike K intruding again. For all of you who have any questions just about anything related to Z codes and coding and capturing that information, send them to us before the session, and then we can tailor the session more if we know what some of your concerns or questions or issues would be. Love to get that sort of as a head start for the next session, so just keep that in mind. And really appreciate everybody's participation today. This has been really helpful.
Thank you.
Thank you very much.
All right, I don't hear anybody else say anything, have anything else. Thank you, everybody, for joining. Look for that poll.
Thank you.